Good morning. My name is Chad Bishop. I live at 7405 South Valencia Drive in Sioux Falls. Our family has lived in what is currently District 12 since we relocated from Rapid City in 2012. Given this, my statement is primarily directed towards our Representative Arch Beal, Representative Greg Jameson, and Senator Blake Curd. With that said, I now see Senate Bill 211, brought by request of the Governor, is scheduled for a hearing in the Senate Commerce and Energy meeting on February 8th. Per the instructions in the agenda, I intend to submit both my written and read statements to the committee. So, thank you for the opportunity to address your committee. Given the timing of this hearing and the level of my preparation when I began this evening, I hope you'll forgive both my disjointed writing and the production quality. The assertions and references in this statement should lead to relevant questions of subject matter experts to be answered either in committee, in writing, or during the debate of this bill. The relevant questions that I would ask if I were representative or a curious journalist can be found in Appendix A. With that said, if you find it thoughtful, credible, and compelling, I would request that you share it. I recorded this statement in an effort to be respectful of my representative's limited time, so that it might be consumed at their leisure, with the relevant references and associated questions for their reference. I make no appeal to credentialism here, but would offer that my professional experience has taught me to ask questions that can lead to meaningful insight. I write offering these thoughts in good faith as a concerned citizen without special training in any of the subject matter. My intention is not to question your intelligence, but to ask intelligent questions. Any errors by commission or omission are in good faith, and I welcome feedback offered in good faith, whether it be for guidance, correction, or clarification. In the spirit of diffusing the artificial political and social tension surrounding the issue of community immunity, I am petitioning you in an attempt to influence the legislation being considered regarding natural immunity and the COVID-19 mandates. Let us move past the divisive framing of this issue as the vaccinated versus the unvaccinated, and let's progress to a more unifying message of the voluntarily vaccinated, plus the COVID-19 recovered, plus the justifiably skeptical, and use community immunity to bring unity. In this statement, I hope to argue effectively for the following three improvements to this bill. First, eliminate the weasel word escape in Section 2, Item 5, which materially undermines both the spirit and the letter of this bill. Instead, consider offering a method of relief through reimbursement from the $974.5 million sitting in the state treasury, which was earmarked specifically for COVID-19 relief. Preserve the rights of the individual above all. Second, eliminate the 180-day testing loophole in Section 1, Item 3. 5 days ago, the Journal of the American Medical Association published extending the previous 6-month durability data to 20 months. In addition, the fact that the vaccines do not prevent infection nor transmission destroys any ethical argument for mandate. Third, amend the bill to direct the Secretary of Health to reimburse any resident of the state for a SARS-CoV-2 antibody or adaptive T-cell response assay, including those that differentiate between S-type antibodies and N-type antibodies, so as to potentially obviate the need for further boosters. How effective is it for us to acknowledge natural immunity but not enable our citizens to determine their immune status? The Governor acknowledges the importance of easy, accessible, and free testing for identifying the infected and protecting the vulnerable. What I am advocating for is making testing for immune status just as easy, just as acceptable, and just as free in order to protect our liberties. We have over $974.5 million in the state treasury specifically for COVID-19 relief. This is an ideal and legitimate claim on those funds given their stated purpose. I hope to explain why this would provide both a path to protecting our rights, managing our risk, and reuniting our people. At the time of this writing, we see what some have called medical apartheid implemented in some of the largest cities in the United States. Identification demonstrating vaccination status is required in New York City, Boston, Chicago, Washington, D.C., and most recently, closer to home, Minneapolis. I do this in the hope of acknowledging there is a proper tension between public health and preserving our individual rights and liberties. My intention is to do this credibly by proposing policy which will improve the application of the relevant science, understanding of the data, and the prudent use of our public funds. I am hopeful that these proposed provisions will strengthen the bill, increase the probability of its effective execution, and broaden its acceptance by South Dakotans. My previous attempts to engage the Sioux Falls City Council, the Sioux Falls School Board, and our U.S. congressional representatives on this subject can be seen and read, at least in part, in Appendix B. I prefer to appeal to the intellect and generally abhor appeals to emotion. Nonetheless, I feel compelled to share our family story. Our family has a slightly different perspective than most and have watched the narrative surrounding the SARS-CoV-2 vaccine campaign with keen interest. This is driven by the fact that no healthcare provider in the U.S. will administer a flu shot to my person. The reason why, as a preteen, I was diagnosed with a rare autoimmune disorder known as Guillain-Barré syndrome. Then Dr. Hart in Aberdeen called it French polio. It attacks the nervous system, and the result was that I was unable to walk for a period of 3 weeks. Thankfully, I fully recovered. My father's oldest brother was diagnosed with Guillain-Barré syndrome as a 67-year-old, up at 4:30 a.m., work until after dark, farmer rancher in Lemon. He spent months at the VA in Fort Meade. He never fully recovered. While he never complained, he continued to suffer until his passing. This looms large in my decision-making because I have seen firsthand what a relapse could look like for me now that I am 36 years older. We understand Guillain-Barré is rare, affecting about 1 in 100,000 people. However, our questions about the potential genetic implications affecting my father, the genetic link between myself and my uncle, as well as my children, my sister and her children, etc., are not understood. The S in Guillain-Barré syndrome stands for syndrome, and the medical community has been honest in that they do not understand its mechanistic cause. The CDC article on Guillain-Barré puts it this way: scientists have several theories about the cause, but the exact reason for this link remains unknown. When I answered a question like this one in a Walgreens informed consent for vaccination form, I was quietly taken aside and scheduled to see a specialist who could explain why I was not eligible to receive a flu vaccine. This question asks, have you ever had a seizure disorder for which you are on seizure medication, a brain disorder, Guillain-Barré syndrome, a condition that causes paralysis, or other nervous system problem? As you can probably imagine, this experience has given me a different perspective. Prior to the vaccine being made available, my wife and I had decided that neither I nor our children would take a vaccine developed under such aggressive time constraints. We are relatively young and metabolically healthy, suffering from none of the comorbidities that were the hallmarks of risk for severe COVID-19 infections and adverse outcomes. We understood that mRNA approach was a different technology. However, there were documented unexplained interactions affecting other autoimmune disorders. In addition, the accelerated development timeline and lack of long-term risk analysis gave us pause. We chose to decline these vaccines. When the FDA attached a warning to the J&J vaccine, specifically regarding Guillain-Barré syndrome on July 12th of last year, we felt our precaution was vindicated. As it turns out, I had reached out to State Senator Al Novstrup in August of 2020 regarding the threat of mandatory vaccination. At that time, I expressed my concerns. Al politely listened. Recalling that conversation now, neither of us really imagined what actually would come to pass. The reputations, careers, livelihoods of our neighbors, friends, and families being threatened for non-compliance with a vaccine campaign. Vaccine development paid for with public funds, sold for private profit, and enforced by fiat and a perverse corporatist union. Now that the tide has turned, some will attempt to reframe this as, the science has changed. Well, I don't believe the science did change. The data changed. That should have been expected given the traditional vaccine development timeline was cut from 5 years to 18 months. Those who are creating policies and making statements in terms of absolutes represent the science poorly and should have had more humility and caution until the data was more mature. In addition to reaching out to State Senator Novstrup, we spoke with our physicians and weighed our options. I also had the benefit of being able to lean on colleagues who were trained in immunology and virology, as we had spent the last year collaborating on antigen-based antibody assays for which we had hoped to be able to diagnose breast cancer. Our eldest daughter had contracted COVID-19 in July of 2020. She recovered and a few weeks later tested positive for SARS-CoV-2 IgG antibodies. My wife, our youngest, and I all tested positive around Easter. We also were antibody positive a few weeks later. So our household had seroconverted prior to any of the SARS-CoV-2 vaccines being available for our age groups. We have had more than a dozen PCR and antigen-based tests since, and have yet to test positive again. The risk is not zero. 4 weeks ago now, I sat with my mother, father, and his primary care physician here in Sioux Falls. We reviewed the results of his electroencephalogram and the neurologist's summary. This EEG, obtained in the awake state, is abnormal, demonstrating occasional epileptiform discharges over the central parietal region. This represents an area of cortical irritability and a potential seizure focus. No electrographic seizures are identified. My younger sister and her family first witnessed the presentation of what the doctor said were likely epileptic petit mal or absent seizures on March 14th of 2021. This was 11 days after my father's first dose of the Pfizer-BioNTech vaccine. He had never presented these symptoms prior to that day. The one time I witnessed him seize was on May 10th of 2021. We were in Culver's on North Louise here in Sioux Falls. He could not walk. He could not hear me. He did not blink. He just slowly slid against the wall to the floor as I tried to hold him. It was as terrifying as it was heart-wrenching. It lasted about 2 minutes. At the previously mentioned appointment, his physician stated that our eyewitness events and the results of his EEG met the requirements for reporting to VAERS, and that he would file my father's case. Now, we are relatively intelligent people. We understand that wet sidewalks do not make it rain. However, you usually start looking for fire where there is smoke. The Journal of Neuroimmunology states it this way: healthcare providers should be aware of the possibility of post-vaccination epilepsy. This layperson's understanding of immunology. In order to understand trade-offs, one has to compare and contrast one's options. It is my understanding as a layperson that the vaccines on offer induce the generation of a single S-type antibody with the accompanying B cells and T cell responses. Comparatively, it is my understanding infection-induced immunity generates not only the S-type, but also N-type antibodies. In addition, there are another 27 antibodies induced from a COVID-19 infection to which our bodies mount a response. Responsible for initial immune response, and then again upon secondary exposure, B cells created during natural infection continue to evolve to become more potent and able to block immune-evading variants. A layperson might also understand there is evidence of a robust and durable T cell response. Lastly, there are the IgA antibodies present in the mucosal layer of our lungs and respiratory system. This is our first layer of defense, where no evidence has been presented that this can be induced through an intramuscular vaccination procedure. In fact, the journal Cell has printed that parenterally administered vaccines do not generate mucosal immunity. Does common sense tell us this has significant explanatory power in helping to explain the rising number of breakthrough infections among the fully vaccinated and fully boosted? This particular band of their spectrum of immunity having been found non-existent? If this understanding is relatively accurate, I would challenge the proponents of those arguing to allow coercion of the COVID-19 recovered to explain how inducing the creation of additional S-type antibodies is beneficial when the recovered already have the ability to produce them on their own. This includes those who would support the 180-day loophole in this bill. What is the benefit? I would challenge you to describe and quantify it. What is the risk? Ultimately, what are the ethics? Currently, one significant deficiency in the bill is that it only enumerates one measure of a single band of the spectrum of COVID-19 immunity, antibody testing. There are also adaptive T cell response assays available. Where does Bill 211's loophole for retesting after 180 days come from? One might argue that the vaccine manufacturers and those who profit from the administration of assays have done an excellent job of convincing the public that blood serum levels of IgG antibodies accurately predict clinical outcomes. Claims of waning immunity because blood serum levels of IgG have dropped below some arbitrary threshold. One might ask the following: what are the role of B cells? Or what is humoral immunity? Or how long does it take for B cells to produce more SARS-CoV-2 antibodies upon a secondary infection? Or what are the role of T cells? Or do we still have SARS 2003 recovered persons still producing antibodies 17 years later? Or what does our own South Dakota Department of Health epidemiological data say about the risk of infection, of reinfection? More on that later. On the CDC's recent concession and absolute versus relative risk reduction, what should we make of a report by Reuters citing the CDC's January 19th Morbidity and Mortality Weekly Report, which states, importantly, infection-derived protection was greater after highly transmissible Delta variant became predominant, coinciding with early declining vaccine-induced immunity in many persons. So 5 months after the Israeli government published the largest study to date, stating the risk of a vaccine breakthrough Delta case was 13-fold higher than the risk of developing a second infection, it seems the CDC has finally concurred. If you're following along with the written statement, the difference between the absolute risk reduction and relative risk reduction is demonstrated in the figure included in the previously mentioned CDC report. Please note the significant difference between the risk associated with being unvaccinated compared to the vaccinated or the recovered. This demonstrates the absolute risk reduction. If you can see it, then compare the negligible difference between those who are vaccinated or recovered. Comparisons like this between the vaccinated and the recovered are stated in terms of relative risk reduction. The Lancet article entitled COVID-19, Vaccine Efficacy and Effectiveness, the Elephant Not in the Room, tries to shed some light on why this is done in vaccine studies. Quote, absolute risk reduction tend to be ignored because they give a much less impressive effect size than relative risk reduction. The confusion around this topic has been used for political and propaganda purposes throughout the pandemic. Lest we forget, propaganda that has been used to demonize our fellow citizens and deprive them of their rights. Public policymakers would be more effective if they understood the difference, not to mention more trustworthy. My point in calling this out now is that it speaks directly to the benefit, or relative lack thereof, conferred by vaccination to those who have COVID-19 recovered status. This is key in this discussion because it is the benefits compared to the risks that ethically justify the administration of any medical procedure. This statement from the January issue of the journal The Lancet underscores the point. Some people who have recovered from COVID-19 might not benefit from COVID-19 vaccination. In fact, one study found that previous COVID-19 was associated with increased adverse events following vaccination with the Comirnaty mRNA vaccine from Pfizer-BioNTech. This brings us to the discussion of how durable the spectrum of immunity is when induced by infection. This is relevant to the portion of the bill requiring retesting at the seemingly arbitrary 180-day mark. The journal Cell, published July 14th of 2021, longitudinal analysis shows durable and broad immune memory after SARS-CoV-2 infection with persisting antibody responses and memory B and T cells, summarizes. Taken together, these results suggest that broad and effective immunity may persist long-term in recovered COVID-19 patients. More recently, again The Lancet, in November of 2021, regarding the durability of the spectrum of immunity induced through infection, quote, researchers have also found that people who recovered from SARS-CoV infection in 2002 and 2003 continue to have memory T cells that are reactive to SARS-CoV proteins 17 years after that outbreak. Yet the governor's proposed bill has a time horizon potentially requiring retesting every 180 days. Why? Do we have any evidence in our own state that might call this anti-science loophole into question. It is likely that we have compelling evidence from both public and private sources. First, from the private sector. When it was announced, the Sanford Survive study was reported to help us, quote, know more about their healthcare professionals, potential exposure to the virus, how their immune systems responded, and overall more about the virus itself, unquote, so that we might all, quote, better understand COVID-19, unquote. Given its reported size and scope, it could prove to be one of the most important pieces of epidemiological work ever done in South Dakota, even though the one-year initial duration of the study passed in July of 2021, the data and results have yet to be published. Could you, as legislators, as senators considering this bill, please request the expedited release of this very important data from the Sanford Survive study? Given that even the CDC now concedes the efficacy and durability of natural immunity in COVID-19 recovered persons, wouldn't it be useful to actually know who has had it? Again, we have over $974.5 million currently in the state treasury specifically distributed to our state for COVID-19 relief. Is it possible for this bill to cover the reimbursement of antibody or adaptive T-cell response assays for South Dakota residents so that they might know their immune status? Did you know that as of this morning, the South Dakota Department of Health has documented over 205,000 recovered cases of COVID-19 in South Dakota? Did you also know that when the CDC creates epidemiological models, those models are usually multipliers of the undocumented case count? Because there are so many folks who don't get tested or had subclinical or asymptomatic infections. So how many, above and beyond our documented 205,000, are COVID-19 recovered persons? Why don't we know the answer to that question? And why isn't that number on our state dashboard? Up until August of 2020, our neighbors in Minnesota were submitting their commercial laboratory data to the CDC. According to this CDC resource, they were reporting 8.8% seropositivity in and around Minneapolis. This is when they had reported 46,045 cases. From this, the CDC has estimated infections to be 339,000 at that time. This is a 7 times multiplier calculated by the CDC. Today, the South Dakota State Dashboard reports over 205,000 recovered cases tracked. If our multiplier is anywhere close to our neighbors in Minnesota, it exceeds the population of the state. Now, obviously, I am not claiming that, but what I am asking is, what is our number? How many are COVID-19 recovered? If we add the COVID-19 recovered and the voluntarily vaccinated, what is our estimated community immunity? This is a 1 in 100 year pandemic. Why are we not tracking the antibody positive? Why is it not an option in our contact tracing efforts to follow up with an antibody or T-cell test? Why can't we have the Department of Health reimburse those who would choose to participate in this antibody surveillance and then anonymize the data in the same way that we do with the PCR positives? Here in Sioux Falls, Avera Health was offering their SARS-CoV-2 antibody test for $50. Sanford Health offered theirs for $85. These are full retail prices. A blood draw purportedly cost them around $12. If the state were to negotiate on behalf of the residents, what would those prices look like? Is it possible we could test the entire population for less than 1/20th of the $974 million that sits in the state treasury for COVID-19 relief? Please amend the bill to reimburse for improving our epidemiological practices and cover all antibody and T-cell assays for those who choose to participate. This is probably the most valid claim you will hear on that $974.5 million appropriated to our state for COVID-19 relief. But until we improve our serological data set, in the interim, what other data do we have? What does our own empirical data, collected by the South Dakota Department of Health, tell us regarding the durability of infection-induced immunity in those who are COVID-19 recovered? On the morning of January 18th, the South Dakota House Health and Human Services Committee heard testimony from the Department of Health, In responding to questions, the state epidemiologist Dr. Clayton informed the legislators that the number of reinfection cases has risen to 4,000. Dr. Clayton also reported that 18 of those individuals sadly died after reinfection. The doctor did not speak to the demographics of either the reinfected or the deceased. The Department of Health COVID-19 dashboard on the Tuesday prior to this testimony reported 174,029 recovered cases. That would mean the updated reinfection rate for South Dakota is approximately 2.3% over the 22 months since the first case in our state. It would mean that the mortality rate among the reinfected is approximately 0.01% across all demographics in our state over that same period of time. For comparison, the editor of the Rapid City Journal tweeted this table stating it was too important not to share. It contains a summary of cases, hospitalizations, and deaths for the not fully vaccinated, but inexplicably omits the fully vaccinated. I responded with the following table, asking the Department of Health representative to confirm the two columns on the right, inferring the cases among the fully vaccinated. So, 2.3% of COVID-19 recovered persons over 22 months were reinfected. Compare this to the 14.6% of cases being breakthrough cases of the fully vaccinated over approximately 9 months since May 1st. So what is the point of this? It demonstrates our own empirical evidence effectively undermines the narrative that vaccination is more efficacious than prior immunity in preventing a COVID-19 infection. In addition, Dr. Fauci informs us the viral load in breakthrough Delta cases was nearly identical to that of the unvaccinated. This in turn undermines the narrative that the vaccine also prevents transmission. The fundamental ethical question is what benefit does vaccination provide to the COVID-19 recovered or society by mandating their vaccination, and does it offset the potential risks, which may be small but are not zero? Given the reality that the risk stratification for adverse outcomes from COVID-19 are 1,000 to 1 when comparing the diabetic and clinically obese elderly person to the metabolically healthy 18-year-old, why does our policy not evaluate these risks upon age and known comorbidities? Lastly, the Journal of the American Medical Association just this week tells us, quote, in this cross-sectional study of unvaccinated U.S. adults, antibodies were detected in 99% of individuals who reported a positive COVID-19 test result, in 55% who believed they had COVID-19 but were never tested, and in 11% who believed they had never had COVID-19 infection. Anti-RBD levels were observed after a positive COVID-19 test result up to 20 months, extending previous 6-month durability data, unquote. In closing, thank you for your time, and I hope this has given you something to consider as you work to follow the science and not just enforce blind compliance.